Well, welcome everyone. If you're joining us for the first time, welcome. And if you're joining us for the third time, welcome back. We'll give folks moments here to settle in, and we will get started very shortly. Okay, all right. I think we can go ahead and get started. So once again, thank you for joining us this afternoon. This is the third and final installment of the webinar series on the clinic collected measures. Today we're focusing on the optional measures here. And once again, we are joined by Peggy and Srida from SAMHSA, who are going to lead us in today's conversation. So once again, welcome. I would like to plug that if it's your first time joining us and you missed the previous two sessions that was led by SAMHSA on this particular topic and you'd like to get access to the recording and the slides, please reach out to myself or Ritu Dar of the National Council, and we will share the previous two um, webinars with you. Next slide, please. So as a quick reminder, this webinar is being recorded and closed captioning is provided. As we do with as we have done with the two previous sessions, the recording will be made available after today's conversation, and it will also be made available on the SAMHSA CCBHC website. Give it about roughly a week or so for the materials and the recording to be posted on that SAMHSA CCBHC website. To ensure that we are not disturbing our speakers today, please mute your lines, and you have the opportunity to enter in questions and comments and remarks, and our presenters will address those within their presentation and at the end as well. Next slide, please. So we understand that folks are eager to ask their questions, and what we are asking here is that you actually use the Q&A box below the Zoom platform to enter in your questions instead of the chat platform. We're asking because we want to make sure all the questions are centralized in one place so that we can have the opportunity to be able to address your questions without having to move between Q&A and chat. So please use the Q&A to ask all of your questions that you may have. Next slide, please. As a reminder, these are the intended audience for the webinar. So anybody that works with the prospective and existing CCBHC that's part of the demo state, or any independent state that are looking to move the CCBHC model along with our PDI and IA's CCBHC expansion grantees, along with our SAMHSA GPOs. So with that, I'll pass it over to Peggy to begin today's conversation and discussion. So
And
Peggy,
I was muted, sorry. Yeah. Thank you, Clement, and thank you to the National Council as well. And good afternoon, everybody. It's nice to see so many of you on this webinar about the optional clinic collected measures. I'll talk in a little bit after a couple of polls about the optional nature of these measures. First, though, I want to briefly introduce them. All of them relate to identification of a need and directly or indirectly to provision of a response to that need. And whether or not as CCBHCs you collect and report any of these measures, the substance of them or why they are included remains important for your clients. The four measures I'll discuss today are controlling blood pressure, or CBP, the suicide risk assessment, are SRA measures for adults and children with major depressive disorder, TSC, or the tobacco screening and cessation intervention, and the weight assessment and counseling for nutrition and physical activity for children, adolescents measure, which is called WCC. Also, I'm going to try to stop briefly, very briefly, for questions between each measure. And there will be much more time at the end. I am not going to go into as much detail on these measures, these optional measures, as I have on the earlier measures. And if you put a question in the Q&A, please identify upfront what measure it pertains to. And please do use the Q&A rather than the chat for questions so Shweta can easily identify them. So we have our first poll today, and this is for clinics only. So if you're a state or some other entity, please do not answer. I work at a clinic. That is, identify the best answer. An existing Section 223 demonstration CCBHC. 2, a CCBHC PDI or IA that is not also in an existing Section 223 demonstration state. Neither of the above, or I am unsure.
All right, Peggy, we're gonna give folks a few seconds here to participate, and I will review the responses very soon.
Thank you. Good. Okay, that's great. We have a representation kind of across the board, but it's about 30% of you are existing CCBHCs within the demonstration. About 47% of you are have discretionary grants, the IA or the PDI, but are not part of a demonstration. I know that there's some of you that are probably both, but I didn't include that as an answer. So thank you. And I think I can close this out. Yep. Okay. So then we're going to move on to a second poll. And I promise this is the last one for a long while. This is for those of you who answered that you are a current demonstration clinic only. So if you work at a clinic that is in an existing demonstration, CCBHC, do you know whether your state will require any of the optional clinic collected measures for calendar year 2025 and beyond? And you have really three options. The first is no, I've heard nothing about my state requiring collection of any optional measures going forward. Yes, I know my state will require one or more of the optional clinic collected measures. And then I am uncertain. And I am uncertain could be that you've heard something, but you're not sure really what the state of the world is, so what's going to happen. So do the best you can with this one. I just want to get a sense of possible use and what people are aware of. Okay. All right. Oh, this is really interesting. So about a quarter of you haven't heard about any requirement, and that's perfectly fine, and maybe it'll stay that way. And then almost a quarter of you do know that your state will require one or more of these. Okay. And then the remainder are uncertain. Okay. That sounds good. So I'll close that out. Thank you. Okay, I'm going to briefly stay on this slide and talk a little bit about why I asked this question in somewhat more detail. Some of the optional measures are currently required of demonstration clinics, and it's possible that existing demonstration states may elect to continue to require one or more of them, either to maintain focus on an important area, to enable continued trending of your results, and or to keep them in your state's quality bonus program as part of the demonstration payment system. So as I walk through these measures today, I will try to remember to always identify which have been required thus far in the demonstration, I also want to let you know that my goal today is not spend as much time, as I said, in detail as the slides might suggest. The slides are fairly comprehensive and can serve as a reference for those of you who need them. So for example, I will not be mentioning stratification, except for right now, as I covered that in pretty fair detail 2 weeks ago, and the information is available in general in the specifications and in detail, or in general on the slides and in detail in the specifications. Okay, so the first measure that I'm going to talk about is tobacco use screening and cessation intervention, or TSC. This has been a required measure in the demonstration since 2017, and we decided after a lot of debate to move it to optional in order to alleviate reporting burden on clinics. The measure covers clients ages 18 and older and involves assessment of need and initial intervention. This measure is very similar to the alcohol screening measure, ASC, that was discussed on the first of these 3 webinars and which is still required. Like ASC, the specs for the TSC measure are NCQA stewarded, and we're still working with NCQA to get them out to you. We have put at the top of the chat, hopefully it's there at this point, directions to access the MIPS version that we are using. I've also included before that the link to the preliminary version of the specs that are on our website. And then I have these directions to the TSC measure and 2 others that follow. I also want to note that the specification includes a definition of tobacco use that is broader than it was in 2016. I'm not going to go into that. I have it. If people really want to know at the end, I'll tell you. But to briefly summarize TSC, it calculates the percentage of clients aged 18 years and older who were screened for tobacco use 1 or more times within the measurement year and who received a tobacco cessation intervention during the measurement year or in the 6 months prior to the measurement year if they're identified as a tobacco user. It includes 3 submeasures, with the third, as with ASC, included only for those who may have been reporting it as a MIPS measure for a long time, and I'll talk more about that later. So in general, the 3 submeasures are just screening for tobacco use, and then secondly, if there was a positive screen, did they receive a tobacco cessation intervention? And the third is a combined measure. So this measure is supported or supports a U.S. Preventive Services Task Force grade A recommendation that clinicians ask all adults about tobacco use, advise them to stop using tobacco, and provide behavioral interventions, and FDA-approved pharmacotherapy for cessation in adults who use tobacco. For quality improvement purposes, the measures support implementation of routine tobacco screening and the provision of cessation intervention to those who screen in as users of tobacco. So these screenings and interventions are best practice, whether or not you choose to collect the measure or simply just to implement the intervention on your own. The data source for this would be your medical records, preferably electronic. The measurement periods are when you need data, are all the measurement year, also which is the same as the calendar year going forward as of 2025, except for a look back of 6 months in 2024 for the numerator, and I'll talk more about that in a minute. Submeasure 1 on screening is pretty straightforward. The denominator is all who have specified encounters during the measurement year and who are 18 and older, with some exclusions related to hospice use. And you meet the numerator if all of those in the denominator were screened at least once during the measurement year. This practice example depicts what I described on the previous 2 slides for the denominator and the numerator. I'm not going to walk through this one in great detail, but we'll walk through the submeasure 2 example. And I can come back to this at the end if people want to see it again. Submeasure 2 of TSC is the tobacco cessation intervention. In this case, the denominator is the same as submeasure 1, but you add in consideration of whether if they were screened for tobacco use and identified as a tobacco user. So in addition to looking at the encounters, the age, and excluding people with certain hospice use, you then look at, in submeasure 1, were they screened and were they identified there as a tobacco user? And so the numerator is satisfied if all of those in the denominator on the previous slide received tobacco cessation intervention during the measurement year or in the 6 months prior, which is why you need the numerator look back on this one. Okay, so I am going to go through this one in detail. I'm going to start with the denominator. So this particular CCBHC had 2,500 individuals receiving a CCBHC service in the measurement year. So these are discrete individuals. And of those 2,300, their service met one of the appropriate encounter codes that's in the specification. Of those 1,500 were 18 or older on the date of service. Of those 1,400 had no hospice use during the year. And out of those, 850 screened positive for tobacco use during the measurement year or in the prior 6 months. And the denominator, therefore, is 850. For the numerator, you take that denominator of 850. Of those, 600 received the intervention, and 250 did not receive the intervention. So the numerator is 600. And the rate on this measure is 71%. This slide includes information taken from the specification on the TSC measure and how it defines a tobacco cessation intervention. I'll go through the top part. The note is there. It's also in the specs. It's all in the specs. For purposes of the TSC measure, a tobacco cessation intervention includes brief counseling, 3 minutes or less. It can be longer, and or pharmacotherapy. So TSC submeasure 3 combines the screening and intervention into one measure. And as with ASC, this is included for those of you who may have been already reporting TSC as part of MEPS before 2018. I won't go through this one in detail. I will just note that it does combine both the screening and the intervention in one submeasure. It has the same denominator as submeasure 1, so no difference. Okay. And the numerator is more complicated because it asks you to look at whether they were screened and what the results of the screening were, and if they were screened positive, if they received a tobacco cessation intervention. This slide will be here for your reference. I'm not going to try to parse it out today, though, because I suspect that most of you probably will not be using this part of it. Okay. And this is the practice example for TSC submeasure 3. And I won't go through this one in detail. Okay. So this slide gives you some guidance on what you might do to prepare in 2024 if you were to report this measure for 2025. Many of these to-dos might also be good guidance, even if you don't report the measure. So in 2024, you could begin preparation for tobacco use screening and tobacco cessation intervention if you're not already doing it. Determine where, when, and how in the clinic workflow that screening and, if needed, intervention would be implemented and documented. Prepare documentation systems that are needed to capture whether screening and, if needed, interventions have occurred. Train staff regarding the screening, intervention, and documentation. If you're going to collect the measure, begin collecting data for the numerator by July 1st, 2024. And for those of you already reporting, determine if you fall into a category that does or does not need to report submeasure 3. So I am going to pause here, and I'm going to take one question on TSC and try to answer it because we have 3 other measures to get through. So I want to make sure I have time for them and to do them justice. So Shweta, do we have any questions in the chat that relate specifically to TSC?
Yes, we do have a few questions.
Okay.
So the first one is asking why TSC is an optional measure, and because smoking is such a serious problem among SBMI is what they say. So that's the first question.
Okay, yeah. And that's a really good question. And like I said, we debated this. We had a lot of tensions that we had to balance in terms of deciding which measures to require. Under the demonstration that began in 2017, the demonstration clinics were required to report 9 measures. And then the states also have to report measures. And conscious of the fact that we are also adding a lot of new, we will be adding a lot of new demonstration CCBHCs, as well as we're going to have CCBHC expansion grants coming in, being asked to report the required measures. We wanted to reduce burden. And so this really was a balance. It was a balance between keeping a really important measure as required versus trying to minimize burden and also allow us to move into the required measures, 1 or 2 that we didn't have before, including the SDOH measure. So that is why it was not an easy decision. And I think I can say the same about 2 other measures that I'm going to be talking about today. But that's a very, very valid question. I appreciate you asking it. And Shweta, I'm going to move on, and we will have lots of time because I'm going so fast. We'll have lots of time at the end for more questions. Okay. So the measures of suicide risk assessment for adults and children with major depressive disorder have been required in the demonstration since it began. And this one really, really involved a lot of debate. We shifted this to optional for a number of reasons. First of all, it was part of that balance in trying to balance burden versus important measures. Also, at least some of the demonstration states had reached a point where they were consistently doing very, very well on this measure. And we expect that the use of suicide risk assessment will remain in place whether the measure continues to be required or not. Secondly, it is now only specified as an electronic measure. So that went into the decision process. And all of those together, really with the idea of also trying to reduce burden. We know that you know that suicide risk assessment is very important. And we recognize that, but we also wanted to reduce the amount of burden that you all have to take on in terms of reporting these measures. So my guess is that if demonstration states are going to continue to require any of these optional measures, these will be ones that are likely to be included. The already published preliminary version of the specs, and that is one of the links that I put on the chat at the very top of the chat, do include a guide to the stewards published ECQM specs and a link to those published specs. ECQM is electronic clinical quality measures. So the adult SRA measure calculates the percentage of all client visits for those clients that turn 18 or older during the measurement period in which a new or recurrent diagnosis of major depressive disorder was identified and a suicide risk assessment was completed during the visit. This and the child version, which I'll talk about on the next slide, are both episode-based measures, meaning that they look at episodes of major depressive disorder and related visits, which may be multiple, especially for the child measure. The child SRA measure calculates the percentage of client visits for those clients who are ages 6 through 17 years with a diagnosis of major depressive disorder with an assessment for suicide risk. You may have noticed that the trigger for an SRA differs between the adult measure and the child measure. I will get to that in more detail in a minute, but in brief, the trigger for the adult measure is a visit in which a new or newly recurrent diagnosis of major depressive disorder is identified. While for the child measure, it is any visit with a child or adolescent who has a diagnosis of major depressive disorder. The CDC has final data on deaths from suicide in 2021. The data from 2022 and 2023 are still provisional, but they look sadly even worse than 2021. In 2021, suicide was among the top 9 leading causes of death for people ages 10 to 64. And suicide was the second leading cause of death for people ages 10 to 14 and 20 to 34. For your quality improvement purposes at CCBHCs, the measure focuses on implementing a routine suicide risk assessment for those with major depressive disorder, with the objective of better and more consistently identifying people in need of further intervention to prevent suicide. This also is a measure that will possibly remain as optional for use by demo states for quality bonus program purposes. As I already mentioned, the SRA measures are only available as electronic clinical quality measures. And the links that you see here on the screen, and which you will be able to actually link to when you get the slides, are the links to get you to the specifications for those measures. Those links are also included in the guidance that we include in the resource manual that's already available on the website. Although the period for which data are needed is generally just the measurement year, I do want to say for the adult denominator, to determine if an episode is recurrent, you will need to be able to look back 105 days to determine if it's recurrent or ongoing. So was there a major depressive disorder diagnosis for the person in the past 105 days? If yes, they came to this visit with that diagnosis already as an adult, the visit's not addressing a new or newly reoccurring episode. If no, it would either be new or newly reoccurring. I want to note, however, that the 105-day distinction is just an operational facet of the measure specification and not any sort of clinical guidance or guideline to distinguish existing new or recurrent episodes for other purposes. I will go through the next few slides on the 2 SRA measures in some detail. However, for programming purposes, clinics that do use this measure or any of the electronic versions of the next 2 measures should have their data people, your data people, look at the electronic specifications for more detail. And once they have done that, those of you who are clinical or administrative in focus and charged with implementing these quality measures and making sure they get reported should have conversations with your data experts regarding how your clinic needs to implement certain procedures in order to satisfy the measure. So the denominator for both the adult and child SRA are identical, except for age. Think of it as all visits by a client you see during the measurement year, divided into adult, those who are 18 or older at any point in the measurement year when there's a new or newly recurrent episode identified, or child if they're ages 6 through 17 and have an MDD diagnosis during the measurement year. And it doesn't matter for children and adolescents whether the diagnosis is new or existing or recurring. As I already mentioned, there is a different trigger by age for when you have a visit where an SRA must be completed to satisfy the numerator, and hence the measure. For those younger than 18, an SRA should be performed at every visit with a major depressive disorder diagnosis during the measurement year. For those who are 18 or older during the measurement year who experience a new or newly recurrent episode of MDD, the SRA must be conducted during the visit when that new or newly recurrent episode is identified. Okay. So I have here a separate practice example for SRA adult, and on the next slide is SRA child, and I'll walk through each of them. So you begin the denominator. You have a certain number of CCBHC visits by people receiving a CCBHC service during the measurement year. In this case, there were 9,867 visits. Out of those visits, in which there were 1,750 where a new diagnosis of major depressive disorder, either a single new or a newly recurrent episode, is identified, and the client is age 18 or older at some point during the measurement year. That gets you to a denominator for the adults of 1,750 here. You take that 1,750 in the denominator, start with that for the numerator, and then you look at whether a suicide risk assessment was conducted in each of those visits that involved identification of a new episode or a new recurring episode. So you have 1,700 out of 1,750 who received an SRA during the applicable visits, 50 who didn't. So your numerator is 1,700. And here you have a stunning rate of 97% compliance for the adults. Okay. And this is the example for the child. I'll go through this one too. Same number of visits by people to the clinic. And then out of those, 3,400 visits were with a client who was ages 16 through 17 years and had a diagnosis of major depressive disorder. Doesn't matter if it was new, old, as long as it's a current active diagnosis of major depressive disorder. And so that takes us to the denominator, which is 3,400 visits. Take that denominator up here to the numerator. You start with that. Out of those 3,400 visits, an SRA was conducted during each of those visits in 2,500 instances, 2,500 visits. In 900, an SRA was not conducted, and therefore the numerator is 2,500. And you have a rate of 74% for the suicide risk assessment child measure. This slide includes language that comes from the specification and is in the guidance in our tech spec manual. Specifically for adults, the suicide risk assessment is defined as follows. The specific type and magnitude of the suicide risk assessment is intended to be at the discretion of the individual clinician and should be specific to the needs of the client. At a minimum, suicide risk assessment should evaluate suicidal ideation, the client's intent of initiating a suicide attempt, and if either of those is present, the client's plans for a suicide attempt, is there one, and whether the client has the means to complete suicide. There are low burden tools to track suicidal ideation and behavior, such as the Columbia Suicide Severity Rating Scale and the Suicide Assessment 5-Step Evaluation and Triage, which can also be used. Because there is no validated assessment tool or instrument that fully meets the requirements in steps 1 through 4 above, individual tools or instruments have not been included as specifically required. You certainly can use them, but you need to make sure that they cover those 4 steps that are listed on the slide. And that is for adults. For children, the language is similar but different. So again, you have the point about the type and magnitude of the risk assessment is at the discretion of the clinician and specific to the needs of the client. But for the children, what is noted as being required is evaluation of risk and protective factors. And they give some examples here of both that may influence the desire to attempt suicide, the current severity of the suicidality, and the most severe point of suicidality in the episode and in their lifetime. So it looks as though this is a consideration of relative suicidality compared to what you know about the client based on prior experience or don't know. And again, there are low burden tools that can be used, such as the Columbia scale, but the factors listed in 1 through 3 do need to be considered. And there's additional information provided on how you might use this in programming. I probably shouldn't have included that, but it's in the spec. Okay, so for the suicide risk assessment measures for people with major depressive disorder, if your clinic is going to be using these measures, or even if you aren't, the slide contains some guidance on preparation. To meet the measure, preparation in 2024 might include beginning preparation for suicide risk assessment for all children with a major depressive disorder diagnosis and for all adults where it's newly identified or a new reoccurrence is identified. This is just the minimum to meet the measure. Determining where, when, and how in the clinic workflow that the SRA will be implemented and documented. Preparing documentation systems to capture whether it was conducted and the results that you obtained, and training staff regarding conducting SRAs and documentation. Also very important because not expressly addressed by the measure. If a suicide risk assessment indicates risk of suicide or self-harm, be prepared to respond with the appropriate intervention and to document it. And so I'm going to pause now and take 1 or 2 questions before going on to the remaining optional measures, but I do want to emphasize that this is a measure of use of suicide risk assessment in certain situations. It is a matter of clinical discretion if you need to do others for adults because it's only asking for it at specific times. It's a matter of discretion. The length, brevity, and depth, as long as you cover the necessary components that are included. So I just wanted to say that, and then of course always there has to be the appropriate intervention depending on the results. So I'm gonna pause here and see if Shweta has a question that I can try and answer.
Sure. First question for the SRA measure. For the 105-day look back for the SRA adult measure, they're asking, is the date of the current visit included in the 105-day period?
I would have to look at the exact language that's in the specification to answer that. And I actually, well, you don't want to wait while I try and find it in the specification. I would look at the specification, and if it's not clear, please submit a question to the mailbox so I can answer it for everybody. Okay. it'll go into the FAQs. I think it is possible to tell from the way the specification is written. And also, one thing I want to mention is I think when I was preparing for this webinar and putting this together, I realized that the specifications as written in the current measures don't allude to the measurement period, including this 105-day look back. So that is one thing that we definitely will be modifying when the final measures come out. It's just to be really clear. So, okay, I am gonna move on. We will have time at the end for all the questions that are coming. Well, maybe not all of them, but a good portion of them that are coming in. Okay. So I am going to spend even less time on this measure and on the one that follows. The weight assessment and counseling for nutrition and physical activity for children and adolescents has been in a slightly different form a required measure in the demonstration since 2017. Again, to reduce burden with the updated measures, we moved this one to optional. We also completely removed in the new specifications the adult version of this measure, which similarly has been required for the demonstration clinic since 2017. This also is an NCQA measure with specs to follow. In the meantime, I also put step-by-step directions to access the Medicaid core set version near the top of the chat today. So as written, WCC calculates the percentage of children ages 3 to 17 who had an outpatient visit with a primary care practitioner, a PCP, or an OBGYN, and who had evidence of the following during the measurement year: a body mass index documentation, counseling for nutrition, and counseling for physical activity. You will note that there is an asterisk here, and there will also be FAQ in the specification, supplemental information that we provide on the specification. As we did in the past, we did this through clarifications. We relaxed that requirement for CCBHCs of PCPs or OBGYNs. You will see in the note that medical personnel beyond PCPs or OBGYNs can conduct services contemplated within the specification as long as they operate within the scope of their licensure in the state. Because this is a deviation from the measure technical specification, the deviation should be indicated in the section of the data reporting template where adherence or non-adherence to this technical specification is reported. So if you actually are one of the clinics that has primary care in your clinic, not simply monitoring and screening, but actual primary care, then you may very well be able to do this in your clinic as a PCP. If you do not have a PCP in your clinic, but you have a nurse or a medical assistant or a nurse practitioner who can, then that individual can do it instead. So I just wanted to make that clear. Although the quote that you see here on the slide, which comes from CDC data, indicates that among children and adolescents in the US, the prevalence of obesity over the years 2017 to 2019 generally was almost 20%. I do want to also emphasize that assessment of weight may also have pertinence at the other end of the spectrum, where eating disorders such as anorexia and bulimia also occur in the populations you serve. For your QI purposes, or quality improvement, this measure is designed to focus some awareness on this important physical indicator of health in children and adolescents, and it provides information that's important for whole person care in response to need among the youth that you serve. It also may be a potential optional measure for states in the demonstration for quality bonus purposes. The WCC measure has 3 potential data sources included in the specification. administrative, which relies on claims and encounter data, a hybrid measure or specification, which involves combined use of medical records and administrative data, and electronic health records. Both the administrative and hybrid specifications will be included in the specification manual. And there is a link, which you also see here on this slide, that is in the specification that will take you to the electronic quality measure for WCC. And as I mentioned before, there should be consultation between your data people and clinical and administrative if you're going to be using one of the ECQMs. There should be anyway, but especially. So the link that you see here will be in the manual. There are no look back or look forward periods. This is data is just for the measurement year for this measure. For the denominator of WCC, it's all clients that have an outpatient visit during the measurement year who are between the ages of 3 and 17 as of the end of the measurement year. There also are denominator exclusions involving things such as hospice care, pregnancy, or death during the measurement year. And the numerator includes these 3 separate submeasures. Specifically, was the BMI profile recorded during the measurement year? Was counseling regarding nutrition provided? And was counseling regarding physical activity provided? And I'm not going to walk through this one. It's relatively straightforward. It will be here in the slides for your reference. And my hope is to, at some point, assemble a collection of these practice examples and make them available to you outside of the slides. So for 2024, there are steps you can take if you're going to report this measure or just want to incorporate some part of this into your physical health monitoring for youth within the scope of services in the certification criteria. For the measure, you can begin to ensure that BMI, counseling for nutrition, and counseling for physical activity are captured at least annually for children and youth, and that the results are documented. You can prepare documentation systems needed to capture results of BMI and counseling, and ensure that relevant staff are trained to use that system, and train relevant staff in low burden counseling for nutrition and physical activity. Also important, when BMI or counseling generally indicates physical issues around weight, high or low, you do want to make sure that referral is made for any relevant interventions if they cannot be provided in your clinic. Okay. So I will pause for one question about WCC at this point. Shrita.
I'm not sure if this question is regarding WCC because there is no indication. The question is, if people have multiple visits during the period, is each visit to be counted only once? If people have multiple visits during the period, is each visit to be counted only once?
Okay, that's probably referring to the SRA measure.
SRA, okay.
Yeah, because that is a visit-focused measure. I'm guessing that that's what was intended. And I'm going to try and answer it. Each visit is counted only once for the SRA measure.
Okay. I think we have one question that came through for WCC. Does the measure include any of the counseling or all the counseling to meet requirements?
For WCC?
Yes.
There actually are 3 different rates. So if you capture the BMI, that's one rate. If you capture counseling for nutrition, that's a separate rate, and then a separate one for physical activity. They're reported separately, so there's no combination of them. And so although are supposed to do all of them. If you do one or two and not all three, that'll be reflected separately. Okay, I'm going to move on to the last measure, and that is controlling high blood pressure. This has been an optional measure in the demonstration since 2017. We retained it there because it does address an important aspect of health. This also is an NCQA measure with specs to follow. And again, I included in the chat at the top how to access this. So the controlling blood pressure for adults measure calculates the percentage of clients who are 18 to 80 through 85 years who had a diagnosis of hypertension and whose blood pressure was adequately controlled, defined as less than 140/90 during the measurement year. The same CDC report that I mentioned for the WCC measure also looks at hypertension in the US, finding that over that same period from 2017 through early 2020, the age-adjusted prevalence of hypertension was around 45% of those ages 18 and older. As with WCC, the CBP measure can help you to focus on this important physical health indicator and provide information important for the provision of whole person care. And it also may be an optional measure for demonstration states for quality bonus programs. So as with the WCC measure, this one has three potential data sources, including administrative, which are claims or encounter data, hybrid, which involves combined use of medical records and administrative data, and then electronic health records. Again, the administrative and hybrid specs will be in the spec manual, but if you want to use the ECQM, the link actually didn't turn out as a link on this slide. The web address is on there, and you can access it there, and that link will be in the specification manual. There is a look back period here for the denominator that covers the year prior to the measurement year or the calendar year, and you'll see why on the next slide. The use of the measurement year and the prior year for a denominator measurement period here is to make sure you are only including people in the denominator who have had at least 2 visits with you that meet requirements in the specification, where there is consistently a relatively recent hypertension diagnosis on the visit. It's further limited to those who are 18 through 85 years of age and excludes those who meet a number of different required and optional exclusions that are addressed in much more detail in the specification. So once you have narrowed down the population to the denominator that I just discussed, the numerator looks at whether the most recent blood pressure during the measurement year is within a range that is described as adequately controlled at less than 140/90. So I will not spend time going through this one in detail, but it will be here for your reference. And if you do plan to use the controlling blood pressure measure, these are some steps you can take. For the measure specifically, begin to assure that blood pressure monitoring occurs as clinically appropriate and that readings obtained are documented, and that you prepare documentation systems allowing you to capture that information. Also important when hypertension is identified, it's important to have an appropriate clinician provide or refer to an appropriate clinician to provide any relevant interventions to address high blood pressure. So I'm going to pause here and see if we have one question maybe for CBP.
All right. So the question here is, what about positive screenings that occur at the end of the measurement year and the interventions that was done in the following, will be done in the following year. So the question is, what about positive screenings that occur at the end of the measurement year and the interventions was done in the following year?
Shweta, do
Not-
they specify if that's
yeah,
controlling?
there is no, no.
Okay, I think that probably pertains to the WCC measure. The general idea, I think, of the WCC measure is that the interventions will occur at the same time as the BMI. That would be the ideal, but I don't think it's specified in the specification. That if that is the measure that you're referring to, the person that wrote it, please please specify, either write it again in the chat or the Q&A, sorry, with the measure that you're referring to, so we can answer it properly when we do the response to the questions. And with that, Shweta, I'll turn it over to you for the next few slides.
All right. Thanks, Peggy. We can move to the next slide. Okay, so I'll speak a little bit about some upcoming technical assistance for quality measures. So we had 2 webinars as part of the Clinic Collected webinar series, where we discussed about the required clinic collected measures. And we'll move to the next slide, please. So some of the upcoming technical assistance webinars or office hours will include either in November or December of 2023, we will have office hours to answer any questions you might have on clinic collected measures. In January and February of 2024, there are 2 state director meetings where state collected measures for CCBHC demonstrations will be discussed. And either in February or March of 2024, we will hold a webinar on the reporting template and commonly asked questions for quality measures. And lastly, in March of 2024, we will hold office hours for state collected measures. And that's all. And we can move to the next slide where Peggy will take additional questions.
And actually, I just realized we've used a lot of time. So I'm going to move to the next poll and do that because I think we're about out of time. Comment, could you do that, please? Or reaching. Thank you. So in the last 90 minutes, I have learned a lot of useful information, new information, some useful new information, very little, not sure, other.
So, Peggy,
Mm-hmm. Yeah.
we are scheduled to go to 4 p.m.
Oh, we are.
Yes.
Okay.
So,
Okay.
there's time for questions if
Okay, good,
you like.
good. I started to panic there. So let's go ahead and do this poll. Do this poll, and then we can ask 30 minutes worth of questions. Okay, so 25% of you learned a lot, well over half. Some useful new information. Good. Thank you for doing that. And okay, I'm going to go back. Let's see if I can make that happen. There we go. Okay. Shweta, if you could, I'll try and disentangle all of this.
Awesome, thank you. So the next question is more of a general one. Someone's asking, what does optional measure mean?
Okay. When we released when we identified the updated measures, which came out publicly identified in March of this year in the appendix to the certification criteria for the CCBHCs, we identified a certain number of measures as required and a certain number as optional. And that's true for both the clinic collected and the state collected. If you're a demonstration, there are state collected measures. And so optional measures are ones that SAMHSA is not requiring that CCBHCs collect and report. As I mentioned, however, among the demonstration states, there may be some states that want to continue keeping one or more of those optional measures in the collection. And they may have different reasons for doing that. But if you are, for instance, a discretionary grantee, an IA or a PDI, that is not part of a demonstration, not in a demonstration state, or not in a prospective demonstration state, then there is no requirement that you collect the optional measures, only the required measures. So that's probably the best explanation I can give you of what an optional measure is. It's just, we are not personally, SAMHSA, requiring it.
And the next question's asking if you could explain why electronic measures are more troublesome.
They're not necessarily more troublesome. They tend to be specified separately in a separate system, and the actual specification requires competent programming and abilities that I don't think I would want to try to explain to you because I would not do a very good job of it. It's troublesome for me. I think that for somebody, I think that if your clinic has good IT support, it should not be an issue. I'm not discouraging you from using them. In fact, over time, electronic and digital measures, that is, measures that rely on electronic health records and programming to pull out the information from the electronic health record, are going to be more and more common. So I don't want to give electronic measures a bad name.
Next question is, when does SAMHSA anticipate putting out a finalized version of the quality measures?
The sooner the better. I hope as soon as possible. I cannot tell you any more than that. That's why I have been trying to make sure that you have a step-by-step guide in the chat to access the measures that are that I'm referring to, that are not in the preliminary version that are on our website. I think I saw some comments that it's not possible to actually click on links in the chat. And I think, except for the first one where I put the link to the specs themselves, which is on the SAMHSA CCBHC website, the others are all on the CMS website. And what I did is I gave detailed step-by-step directions of, I gave the actual address in most cases, or told you where to go on a page once you got there. So even if you cannot click on the link for the three that I included, the directions on how to get to them, you should be able to take those directions after you get off the webinar and follow them and be able to get to the specifications.
The next question is about the WCC measure. Does the BMI percentile need to be documented during the eligible encounter or during any point in the measurement year?
What you need to have is you have to have somebody who comes in who is seen. That's the encounter, basically. And the BMI very well may be captured and recorded by a nurse, or if you have a doctor in the clinic. So I would say it might be very hard to actually do that. But they have to come in to be seen to be able to do it. I think you need the eligible encounter for the counseling. Definitely.
The next
Yeah,
question's, oh, I'm sorry.
I was just reading a chat down at the bottom about how a
Mhm.
care coordinator captures the BMI in the one case. Sorry, Shweta, go ahead.
So I think the next question's more logistics. When we would schedule the 2023 office hours.
The slide does say no, it'll be November or December. It will be December, I'm pretty sure. And I am working to get those scheduled within the next week, definitely by the end of next week.
Okay. So is the CBP required, is CBP measure required for demonstration sites?
Not as part of the demonstration by SAMHSA. And there are some states, I think Missouri may have been one of them, that required it. But we do not require it. It is optional unless your state specifically requires it and you're part of the demonstration.
Someone has more of a basic question. They say the manual says CCBHCs in the section 223 demonstration and to any CCBHC IAs or CCBHC PDIs that are required to report measures. How would we know as a PDI grantee whether we're required to report measures? Is this a question for our GPOs?
I can try and answer it. If there's any confusion, it'll be my fault. So I believe it's the cohorts that began in 2022 and 2023 that are going to be newly collecting the measures, the required measures. And again, that will not be until the actual data will cover the period of the calendar year 2025. That'll be the first measurement year that you, as non-demonstration clinics, would be required to report. The actual reporting occurs in 2026 for the first year. Again, demonstration clinics have their own set of separate requirements.
Someone's asking, saying that they're not a that they're not a demonstration site, but they are a demonstration state. So whether the optional measures apply to them.
If you are not in the demonstration, if you're not certified by your state as a demonstration clinic, unless some state's doing something I don't know about, you're not required to. However, if you anticipate possibly becoming a demonstration clinic in your state, in your demonstration state, then yes, if your state requires the optional. Hopefully I didn't lose the thread there.
Next is a logistics question. If there are feedback or questions for earlier webinars, who we should contact.
Yes, let me advance the slide here so that you all have it in front of you. Oh,
and I
first,
can add.
Yeah, I just want to mention, sorry, Shweta, sorry I interrupted you. These are the references for the slides earlier. And then, okay, so this is the last slide in the deck, and everybody here will get these slides. You see there under, in the blue, the light blue, the submission, CCBHC measure submissions mailbox. If you have questions about any of the measures, you can submit them to that. we try to answer them as rapidly as we can when we're not busy trying to get ready for one of these webinars. And ultimately, what's going to happen is we're going to be pulling the questions and answers together if they are generally applicable and pulling them into FAQs that everybody will have access to. So one avenue for you to ask questions on the other measures is through that. The other avenue is we will be having office hours, and I'm going to try to get that scheduled, like I said. It will happen in December sometime, and you will be made aware of that and can ask questions at that point too. That will just be for clinic collected measures.
All right. The next question is regarding the WCC measure. Does the encounter need to occur with a primary care provider or an OBGYN? Or has that been expanded to MDs and APRNs, which are the, I'm guessing, advanced practice registered nurses? They're saying we know the BMI can be collected by nurses, but unsure if the encounter is counted towards the measure.
The entire measure aspects of the entire measure, any part of it, whether it's the counseling or the BMI, can be collected by medical professionals other than PCPs or OBGYNs, as long as you're practicing within the scope of your license in your individual state. That includes the counseling, that includes the BMI, any of it.
Okay. The next is a general question. Are there any recommendations for EHR systems that have been built in and that have some built-in infrastructure for some of the quality measures? Apparently this person's looking for a new vendor and would appreciate any recommendations for EHR systems.
That would have to come from somebody besides me. There are probably a lot of people on this call, your peers on the call, who have experience and might be able to share that information. I would not be in a position to either know or be able to advise, and couldn't anyway, because I can't recommend any particular vendor.
The next question is for, they're asking for state collected measures. What responsibilities do the CCBHCs have?
Okay, the state collected measures, and sadly, I think that the two state programs are going to be kind of confined to state personnel. So what I want to do eventually, after I've had those two meetings with the state staff on the state collected measures, is also have a separate webinar at some point that covers clinics and let you know more about what the state collected measures are. So let me say that first. But secondly, the measures that the states collect are collected by the states in general because they have better access to the data. A lot of them are administrative, and some of them are ones that, for instance, track follow-up after hospitalization of one of your clients or ED visits. And they have access to at least for the Medicaid data, they have access to that. And it's going to be more accurate coming from them. So that's why they have a lot of measures, actually. And so if you are a demonstration state clinic, then your state will be collecting a fair number of measures at the clinic level using administrative data. If you are not in the demonstration, there's no your state is not doing that. There's no reason for the state to be doing it, at least as far as we are concerned. We don't have any requirements. What ideally what would happen is that what you're being measured on, you would know what you're being measured on and you would know how you're doing. Unfortunately, administrative data often lags by quite a while, and it's hard for states to get that information to the clinics. The clinics ideally would be able to use that information to make quality improvement changes. My wish is that states could find ways to do that on a more rapid basis than waiting until the end of a year until all the data are in, to be able to let clinics know how you're doing. So you can adjust your processes in a more timely fashion. But if that's not possible, what I would say is you should be familiar with the measures that the states are going to be collecting if you're a demonstration clinic, and begin making plans within your quality improvement to try to address aspects of that, even if you don't have ready, quick access to the data and the results.
We have a question where someone's asking the difference between CQM measure and ECQM measure and the relevance to these measures to the specification.
Okay. CQM is just clinical quality measures, to kind of give a simplified answer to that. ECQM are electronic clinical quality measures. And so the ECQMs are specified in a different way than the traditional clinical quality measures. The traditional clinical quality measures look more like what you see in the preliminary version of the specs. The ECQMs have very detailed programming instructions to be able to pull information out of your electronic health records. Those are the differences, and the differences also are that some measures are specified as ECQMs, some aren't, and some are only specified as ECQMs.
And there's another question they're asking, just to clarify, if we are not a demonstration state, the state does not need to collect the state collected measure?
That is correct. At least not for purposes of the CCBHCs. Some of these measures that are state collected measures, they're collected anyway by the state Medicaid program as part of the Medicaid core set. And to the extent that we're using a lot of the state collected measures for the CCBHCs, most of them are core set measures. And so we've tried to parallel those to the extent we can. But no, if your state is not a demonstration state, under the CCBHC program, the state does not have any obligation to.
We have a question that's asking for a definition for properly recorded BMI for children.
Okay. That is a question that should go into the email box. What I would suggest you do is to follow those access steps for WCC to the core set specification, and look there. And if you can't, or if you don't see what you need, do ask the question in the email, please.
Next is a logistics question. If we would have any office hours in 2024. This person says that they're having new grantees coming in and they will not be tackling quality measures until next year.
I'm pretty sure we will. Certainly hoping to. I know that over the course of 2024, the CCBHC, the clinics, those of you who are on this call, most of you who are on this call, are going to be very busy trying to implement this, and you're going to have a lot of questions that occur to you then that you may not know now. So yes, they're going to be venues for asking questions, and always that email box is there. But yes, there will be other opportunities. I don't know exactly what form they're going to take yet, but yes.
Next one's about the final specifications and when they will be available.
Okay, that was asked and answered. I don't know yet. I'm sorry.
There's a question about the TSC measure and the link that was posted in the chat. Not matching apparently. So if we could maybe just double check the
Okay.
link.
Yeah, I actually have it written on a piece of, well, I have it printed on a piece of paper here. So I'm going to go through it right now. Control click. There's only one link in the TSC one, so I want to make sure it's right. Yes, it is. Yep. Okay. Let me repost it. Let's see, put it in the chat. This is to everyone. Oops. So these are the TSC access steps. And I can talk you through them too. The TSC is different than the others because the TSC is a MIPS measure and not a core set measure. So it's a different process. So let's see. See if I can move this. Okay. All right. This is very hard to control. Okay. Right. So the first thing you do is you do go to this link, and this link is the CMS webpage where they have their quality payment program resource library. So that takes you directly to the resource library page. On that page, you scroll down until you see a fairly large header that says full resource library. And you go there, and at that point you can select the performance year. You want 2023 because those are the most current ones that are out. It says QPP reporting track. You have a choice. You pick MIPS. Performance category, you pick quality. And resource type, you pick measure specifications and benchmarks. And so when you do that, it will automatically, and it's not one of these ones where you, after you put those in, that you have to push a button that says select or send or anything like that. What happens is that automatically, once you put in those filters, you just look down, and there you will see below the actual specifications and other documents. So when you get to that point, you want to select that 2023 clinical quality measure specifications and supporting documents, and it'll take you to a zip file that'll show up on your computer that's full of different things. And you open that, and there are, if I recall correctly, there are 2 folders, and one of them is 2023 CQM measure specifications. It's a PDF. You open that, and you go to measure 226, MIPS measure 226, and that's TSC. And those are the specifications that are available publicly on the CMS MIPS website. So hopefully that helped. I'm going to get this out of the way now. move it over. Shweta, other questions?
Yes. Someone's asking if we can put the links in the chat again because they attended late and do not see the links in the chat. So
okay, I just did the TSC, so let me do the others, and I have to do them separately because the chat will only hold so much at one time. So the first one I'm going to put in there is oops, where the preliminary version of the specifications are. Put that in right now. Yeah, this is the only one I think where yeah, you just have to, for this one, you have to, for the preliminary version of the specs, you go to SAMHSA's, you just type in SAMHSA CCBHC, and you will see the CCBHC website for SAMHSA. And you'll go, there's over on the left side, there's a section that pertains just to quality measurement. You go to that page and the specs are on that page along with some other things. On the TSC, okay. On the TSC, the only one where you really need the link per se to click on is for the specs. For the TSC, and I'm going to put this in front of the screen so you can see it. This is the chat. Hopefully you can see that. For TSC, ideally you'd be able to link to this by just clicking on it, which I can do, but you can't. So what you do is you copy this. Oops. You copy this and paste it into your browser, and you can go to that page. And once you go to that page, you can follow these directions and get to the TSC measure. So I'm going to do the same thing for WCC and the CBP. So WCC here. Okay, WCC again. Oh, goodness. Sorry. Okay. Again, ideally you'd be able to link on this, but if you can't, you can copy it and paste it into your browser. And then you follow the rest of the directions to get to the specs for WCC. And I'm going to do the same thing for controlling blood pressure.
Peggy, if you're sharing your screen, I don't think folks are able to see it.
Really? Oh no. Okay. Okay. This is all in the chat, and I'm going to put CBP in there. So if you go to your chat, you'll be able to see all this stuff. I was hoping that if I pulled this over that you'd be able to see it, but you can't. Okay. That makes sense that you can't. All right. Any more questions? We have 2 minutes.
I think we covered almost all of them. I think there's one or two more questions. The one question that we have is someone saying that their clinic has a certified tobacco treatment specialist who is not a clinician but can issue nicotine replacement therapy and link clients to prescription medication. They're asking if this would suffice for a screen or a clinician needs to screen the client.
The answer should be yes. If you could email that question, I'd like to address it for everybody, and I want to talk to other people before I answer it. Common sense would say yes.
I think that's
Okay.
I think that's all the questions.
Wow, I can't believe it. So thank you, Shweta, and thank you, everybody. And I'm going to go back to the question. there, the mailbox. First of all, thank you for being patient when I don't necessarily answer your question, because there's some questions that are better answered with the specs right in front of me. And I don't want to mislead anybody. I don't want to give you a wrong answer. So if I tell you to refer to the specs, and if that doesn't help to send an email, it's because I want to be able to answer it properly. The other thing I want to say is thank you everybody for sitting through this. And I wish all the veterans out there restful and peaceful Veterans Day weekend, and everybody else too. Okay. Thank you.